Hello my dear medical coders. In today's video we're going to continue the chapter specific coding guidelines, chapter 15, pregnancy, childbirth and puerperium. Let's get started. This is Surya Johnson, your medical coding guide. If you're new to this channel, I am Surya Johnson. I'm a medical coding professional. In this channel I teach everything under the medical coding world. All about the medical coding guidelines, exams, how to crack the exam, tips, tricks, and how to appear for an interview. And all the questions that you ask in this medical coding field, I'm here to help you out. If you haven't subscribed yet, please subscribe and hit the notification bell icon so you'll not miss any of my future medical coding related videos. In my previous video, we've already covered 4 points under 15 chapter, ICD-10-CM 15 chapter, pregnancy, childbirth and the puerperium, 000 to 09A series. We've already covered the general rules for obstetric cases, then selection of OB principle or first listed diagnosis, pre-existing condition versus conditions due to the pregnancy, and we ended up with the pre-existing hypertension in pregnancy. Because this pregnancy chapter is a very big chapter, and also I wanted to explain each guidelines in detail, that's why I'm just breaking this into part 1, part 2, and I think it will go in part 3 as well, because I think a lot of things should be covered in detail as well. Grab your pen and grab your notes. Let's get started. So the E point here under chapter 15, pregnancy, is fetal conditions affecting the management of the mother. So in certain scenario, what happens? The pregnant patient, the fetus that is inside the womb of the mother, will have some condition or complication. Because of that, the patients, that is the mother, the pregnant women, management should be taken care, and it has a different series of diagnosis. So that will be under this E1, fetal conditions affecting the management of the mother. So under this, the first point is codes from category O35 and O36. So when the patient fetus in the womb has any suspected fetal abnormality or any damage, then we'll be assigning code from the category O35 and O36. So what is O35? O35 is maternal care for known or suspected fetal abnormality and damage, and O36 maternal care for other fetal problems are assigned only when the fetal conditions is actually responsible for modifying the management of the mother. What does it mean? Fetus has some complications or has some anomalies or any damage. What happens is this mother, the pregnant women, will not be considered as a normal woman. So they will be considered as a high risk pregnancy because the fetus inside them is high risk, so susceptible as high risk because of the known or suspected some abnormal or damage or any congenital anomalies. So what happens now from that day onwards, from when the fetus was diagnosed with some abnormality or damage or suspected, this care for the pregnant women should be very much modified. So that is why to denote that this patient is undergoing maternal care for known or suspected fetal abnormality and damage, or for other problems associated with that fetus, we will be assigning codes O35 and O36. So the second point under this fetal conditions affecting the management of the mother is in utero surgery. So in certain scenario, what happens? To treat the fetus abnormality or the damage, they might perform surgery to the fetus while the fetus is still inside the mother's womb. So in this scenario, you will be coding O35 codes, maternal care for known or suspected fetal abnormality and damage. You should be assigning the same diagnosis. You should not be assigning any codes from the chapter 16, which is the perinatal codes. So this perinatal codes should not be assigned to the mother's record, because as long as the fetus in the mother's womb, it is the mother's case, right? So you should not be assigning the perinatal codes, the abnormality or anomaly or any deformity codes from the 16 series, chapter 16 codes should not be assigned to the mother. So the next point under this one is F, HIV infection in pregnancy, childbirth and puerperium. So we already know for HIV, even in normal cases, HIV illness associated with a symptom or asymptomatic should be coded, right? So likewise, if the pregnant patient is having an HIV infection during the pregnancy, childbirth or during the puerperium period, you will be coding the HIV infection complicating pregnancy. Because this is pregnancy, O code should always be the principal diagnosis. So O98.7, which is HIV disease complicating pregnancy, childbirth and puerperium, you should be coding this first. And following these codes, you will be coding the HIV related illnesses. If the patient is having, if the mother is having HIV related illnesses, you will be coding those as secondary diagnosis. So if the patient is asymptomatic, this mother does not have any illnesses, the mother is not having any symptoms related to the HIV, even in that stage, you will be coding O98.7 and you'll be following that with Z21, which is asymptomatic HIV infection status. So this is the general HIV infection guideline. The only point, because here is the patient is pregnant, O code proceeds. So the G point here is a diabetes mellitus in pregnancy. So a patient who is already having diabetes mellitus, DM. So the pregnant patient, even before becoming pregnant, the patient is an established DM patient. So because the patient is an established DM patient, it should be recorded in the diagnosis, because that will affect the management of the mother and the baby. So for this scenario, what you code the O24 series, which is the diabetes mellitus in pregnancy, childbirth and puerperium, because this pregnancy case, followed by the appropriate diabetes code. So what kind of diabetes the patient is having, so based on that, you'll be coding from E08 to E13 series, and this should be secondary, not principal. For the H point, long-term use of insulin and oral hypoglycemics. This follows the general guideline where we already discussed under the diabetes section. You'll be going with the O code first, diabetes mellitus in pregnancy, that O24, followed by the diabetes course, and then followed by that you'll be giving the long-term use of insulin and oral hypoglycemic, whatever the patient current medication usage, you'll be assigning this long-term use of insulin and oral hypoglycemics. I don't want to go in detail in that. So this is how it will follow. The next point here is gestational diabetes. So gestational diabetes is pregnancy-induced diabetes. The patient does not have a diabetes mellitus before the pregnancy. So the patient is a normal, healthy patient without a DM status before. After becoming pregnant, because of this pregnancy, the patient develops diabetes. So in this scenario, it is called as pregnancy-induced diabetes, otherwise known as gestational diabetes. So this will be under the same O24 series only, the pre-existing diabetes series I saw before, right, in the G point. So the same series, but the diagnosis is O24.4, which denotes gestational diabetes mellitus. So when you code this O24.4, you should not be assigning the other diagnosis from the O24 series. So even this O24.4 has some divisions. If, as you can see, it has diet controlled, insulin controlled, controlled by oral hypoglycemic drugs, and unspecified control. So if the patient is gestational diabetes, the pregnancy induced diabetes, and if the patient is in diet control, you will be going with the diet control diagnosis, insulin control and controlled by oral hypoglycemic drugs. Because these and in this scenario, you will not be coding the long-term use of insulin or oral hypoglycemic. Why? Because this patient is not using for long-term. This was an induced only during this pregnancy it started, and maybe this gestational diabetes will not be there in the patient's health status after a few months after delivery, or maybe the patient might continue with this GDM. So be cautious in choosing this, and do not, I repeat it, do not use long-term use of insulin and oral hypoglycemics for this GDM patient. So let's see, the patient is not having a gestational diabetes mellitus, but the patient is having an abnormal GTT. That's the glucose tolerance test. The patient GTT is abnormal, but not a gestational diabetes, not a GDM. Only GTT is abnormal. In this scenario, you'll be coding O99.81, which is the abnormal glucose complicating pregnancy, childbirth and puerperium, and you should not be assigning O24.4 based on the abnormal values from the GTT test. Okay, so don't assume because the GTT lab values are abnormal, the patient is having gestational diabetes, you should be going with O24.4. No, don't assume that one. Unless the doctor, the treating physician, the consulting physician is establishing the condition or diagnosis, you should not choose the diagnosis. The next J point is sepsis and septic shock complicating abortion, pregnancy, childbirth and the puerperium. So when you assign this sepsis complicating abortion, pregnancy, childbirth and puerperium, And you should always mention the specific type of infection as an additional diagnosis. What kind of infection is this? What is the organism? You'll be adding that as an additional diagnosis. So if severe sepsis is present, you'll be coding from the subcategory R65.2, which is severe sepsis, and codes for the associated organ dysfunction should be assigned if the patient is having any organ dysfunction. So the key point here is puerperal sepsis. So what is puerperal sepsis? First, what is puerperal? Puerperal means postpartum. 6 weeks from the delivery, that is 45 days, will be the postpartum, right? So during that time, if there is any infection, it is called as puerperal sepsis, postpartum sepsis. So you'll be coding from the series O85, which is puerperal sepsis. You should be coding this, and there should be a secondary diagnosis identifying the causal organism, like any bacterial infection. You'll be coding from B95 to B96 series. That kind of secondary additional diagnosis to denote the causal organism should be coded with the puerperal sepsis. So a code from the category A40, which is the streptococcal sepsis, or A41, which is other sepsis, should not be assigned for puerperal sepsis. So if the sepsis is after the delivery during the postpartum period, you'll be coding only O85 and not A40 or A41. So if it's applicable, you can use additional codes to identify severe sepsis. You'll be coding additionally as R65.2, and if there is an acute organ dysfunction, you know the drill, you'll be coding that as well. So code O85 should not be assigned for sepsis falling in OB procedure. What does that mean? Puerperal sepsis O85 diagnosis should not be coded when there is a complication or a sepsis or infection that has resulted because of a procedure. An obstetric procedure has been performed. Because of that, there is a sepsis. That is not puerperal sepsis. So you will not be coding O85 series for that. For that, you'll be going directly with the sepsis due to post-procedural infection. So that's a different section. You will not be coding O85. The L point under chapter 15 is alcohol, tobacco, and drug use during pregnancy, childbirth, and puerperium. Under this, the first point, alcohol use during pregnancy, childbirth, and the puerperium. So if the patient is using alcohol during the pregnancy or during the postpartum period, you'll be coding O99.31, which is alcohol use complicating pregnancy, childbirth, and puerperium. And also you'll be coding a secondary diagnosis, which is F10, which is alcohol related disorder, to identify the manifestation of the alcohol use. Likewise, for tobacco use during pregnancy, there is a series O99.33, which is smoking, tobacco complicating pregnancy, childbirth, and puerperium. Additionally, you'll be coding F17, which is nicotine dependence. Same goes like for the drug use during pregnancy, childbirth, and puerperium. There is a diagnosis O99.32. When you'll be coding this drug use O99.32, so when the patient is using drugs during the pregnancy and during the postpartum state, that time you'll be coding O99.32. Also, if those drugs are illegal drugs or is inappropriate use, or even prescription drugs, if the patient is abusing, then in this scenario you'll be coding O99.32. The secondary diagnosis will be from the F11 to F16 series and F18 to F19 to identify the manifestation of the drug use. So this is simple. There's only 3 diagnoses: O99.31 for alcohol use during pregnancy, childbirth, puerperium. For the drug use, it is O99.32. For the tobacco use, it is O99.33. And there will be additional diagnosis to identify the manifestation of this usage. So the last point for this video, not in the pregnancy, not in the chapter 15, it's more to go. We'll wind up with this M point, which is poisoning, toxic effects, adverse effects, and underdosing in a pregnant patient. So for these scenarios, you'll be coding from the diagnosis series subcategory O9A.2, which is injury, poisoning, and certain other consequences of external causes complicating pregnancy, childbirth, and puerperium. So you should be coding this series first, following by the damage or injury or poisoning, toxic effect. What is the adverse effect because of this underdosing? What are the adverse effects or underdosing code? You will be coding those diagnoses secondary. And then additionally, there is some condition or some problem arises because of this poisoning, toxic effect, and all those things, underdosing. You will be coding that also. The first diagnosis will be O9A.2. So by now, if you are fresher coder, you should have already got an idea. O codes should proceed before other chapter specific codes. So other chapter specific codes shouldn't be principal diagnosis for a pregnant patient during pregnancy, childbirth, and puerperium. This is all in the part 2 video of the chapter 15 guidelines, pregnancy, childbirth, and puerperium. If you have any doubts, please put it in the comment section below. I'll maximum try to answer all your queries. If you found this video to be helpful, please hit the like button and share with your medical coding friends so they will get benefited from this like you have. Surya Johnson, your medical coding guide.